once again. We'll refer to the relatively early stage of these disorders collectively as chronic hepatitis, represented by this racing pony kicking up flames next to the grandfather clock. Over time, if chronic inflammation continues, liver tissue is replaced by fibrosis. That's cirrhosis, my friend, represented by this fibrosed concrete scar inside the liver pen. Just imagine flaming dirt over time turning into concrete. It's basic biochemistry, really. Or alchemy, maybe? I don't know. Let's take a look at some of the same features, now from the chronic side. Back to the gnarly liver shrub. Recall that impaired hepatic synthetic function is a sign of severe hepatocellular disease. Here on the chronic side, severe disease is synonymous with cirrhosis, in particular, decompensated cirrhosis, which is why we've placed the shrub low in the scene, on the same level as that concrete scar. Expect both markers of hepatic synthetic function to be abnormal in decompensated cirrhosis. Impaired albumin synthesis leads to hypoalbuminemia, while decreased production of clotting factors leads to prolonged PT and elevated INR. Notice the flapping emu's proximity to the liver concrete as well. Like acute liver failure, decompensated cirrhosis can cause hepatic encephalopathy. Once again, the liver is unable to adequately clear ammonia and other neurotoxins. But that's where the similarities between acute and chronic hepatocellular disease end. Recall that on the acute side, even relatively mild acute hepatitis commonly causes hyperbilirubinemia and jaundice. In contrast, here on the chronic side, early disease does not present with hyperbilirubinemia or jaundice. No jaundice on this horse. The development of hyperbilirubinemia and jaundice indicates progression to decompensated cirrhosis. As in other liver diseases, the pattern is a conjugated hyperbilirubinemia, hence the colored goat on the concrete slab. Once again, injured hepatocytes are particularly bad at excreting conjugated bilirubin into the bile ducts. Decreased bilirubin uptake and impaired conjugation can also contribute to the problem. Unlike its acute counterpart, chronic hepatitis is usually asymptomatic. So the racer in the chronic lane is smiling and symptom-free. Decompensated cirrhosis, on the other hand, is far from asymptomatic. In addition to jaundice and hepatic encephalopathy, patients may present with evidence of portal hypertension, such as GI bleeding from esophageal varices and abdominal distension from ascites, and signs of hyperestrogenism, like spider angiomata and palmar erythema. For a more in-depth look at the clinical manifestations of cirrhosis in all their gory detail, check out our cirrhosis soap sketch. That about does it for chronic hepatocellular disease. For the most part, laboratory tests we've mentioned aren't particularly useful in identifying the underlying cause of hepatocellular disease. But there's one exception: alcoholic liver disease. In the majority of hepatocellular conditions, the ALT is greater than the AST. In contrast, alcoholic liver disease usually presents with AST greater than ALT. In particular, a ratio of AST to ALT greater than 2 is highly suggestive of alcohol as the underlying cause. So on the chalkboard in the back, we featured a wine bottle next to an AST toast. In addition, patients with alcoholic liver disease may exhibit significant elevations of serum GGT without a corresponding elevation in alkaline phosphatase. Heavy alcohol consumption itself is responsible for increasing the GGT, an effect seen even in patients without liver disease. Check out our acute and chronic liver disease DDX videos for a discussion of the many underlying conditions that can cause acute and chronic hepatocellular disease, viral hepatitis of all shapes and sizes, metabolic disorders, autoimmune hepatitis, the works. Next up, wait, what does that say? Cole, Stacy, Pat, Ern. Ah, yeah, the cholestatic pattern of lab abnormalities. This is seen in, well, disorders in which the primary issue is impaired bile flow. You know, stasis of your coli. This time, ALK-Phos is disproportionately elevated compared to the AST and ALT, hence the oversized chalkboard towering over the toasting malt glasses. The ALK-Phos is usually markedly elevated, more than 4 times the upper limit of normal. In contrast, AST and ALT are normal or mildly elevated. Not surprisingly, GGT will be elevated as well. Remember, an elevated GGT can be used to confirm the hepatic origin of an elevated ALK-Phos, particularly useful if other tests, like AST and ALT, are normal. GGT won't be elevated if the ALK-Phos is derived from bone. Elevated bilirubin and jaundice are prominent features of moderate to severe cholestatic disease, hence the relaxed jaundice billy goat up there. Keep in mind that bilirubin may be normal in early disease or with intermittent biliary obstruction. Impaired bile duct flow means that conjugated bilirubin is trapped on its way out of the liver. So expect a conjugated hyperbilirubinemia, as emphasized by the collar on that billy goat. Prolonged severe cholestasis can present with a prolonged PT and elevated INR as well. So we've brought in another one of those INR intercom radio thingies. Why the elevated INR? Well, cholestasis leads to decreased absorption of fats, including fat-soluble vitamins such as vitamin K. Without sufficient vitamin K, hepatocytes are unable to synthesize vitamin K-dependent coagulation factors in the extrinsic pathway. Since vitamin K deficiency is responsible for the elevated INR, a single injection of vitamin K should correct the abnormality within 24 hours. Nice! Compare this to the elevated INR seen in hepatocellular disease, which does not correct with vitamin K. Cholestasis of any cause can also present with pruritus. The exact mechanism is unknown, but it may be related to elevated levels of bile acids. The classic cholestatic lab pattern is seen in two broad categories of disorders. See that clogged green feeder outside the liver enclosure? It represents obstruction of the bile ducts outside of the liver, also known as extrahepatic cholestasis, while that clogged feeder inside the enclosure represents intrahepatic cholestasis, the disruption of bile ducts inside the liver. Yep, intra and extrahepatic cholestasis look the same on laboratory testing. How do you tell them apart? Right upper quadrant ultrasound. In patients with a cholestatic lab pattern, ultrasound is typically the next best step of the workup. Extrahepatic cholestasis often presents with dilated bile ducts as a result of increased intraductal pressure behind the site of obstruction. Depending on the location of the obstruction, the dilated ducts may be extrahepatic or intrahepatic or both. To remind you that duct dilation is a feature of extrahepatic cholestasis specifically, we've placed this dilated green windsock outside the liver pen. In contrast, the bile ducts usually appear normal in intrahepatic cholestasis. One of the most common causes of extrahepatic cholestasis is gallstones within the common bile duct, also known as choledocholithiasis. Patients present with prolonged episodes of right upper quadrant or epigastric pain, accompanied by nausea and vomiting. Some may also have jaundice. Passage of the stone relieves the symptoms. As with other causes of extrahepatic cholestasis, abdominal ultrasound may demonstrate bile duct dilation. In this case, dilation of the common bile duct. Occasionally, the gallstone itself may be detected in the duct as a hyperechoic, bright spot with shadowing. However, overlying bowel gas can get in the way, making it difficult or even impossible to see the stone. Up next, acute cholangitis, which involves inflammation and bacterial infection of the bile ducts. It's represented here by this unexpected flame dangerously close to that biliary windsock. Acute cholangitis usually develops in the setting of biliary stasis from underlying bile duct obstruction. The most common cause of this obstruction? A stone lodged in the common bile duct. Yep, choledocholithiasis. Other major causes include malignant obstruction and benign biliary strictures. Acute cholangitis classically presents with three findings. A triad, if you will. Jaundice, right upper quadrant pain, and fever. This combo is referred to as Charcot's triad, represented by the triangular dinner bell and fashionably short coat. Not surprisingly, acute cholangitis often presents with leukocytosis, a sign that distinguishes it from all other cholestatic disorders. So we've drawn in a few elevated leukocyte white birds. Abdominal ultrasound may demonstrate biliary dilation, or, if you're lucky, more specific signs of the underlying etiology. Obstruction of the extrahepatic bile ducts by cancer is another relatively common cause of extrahepatic cholestasis. So pay attention to that shiny cancer crab belt. Two important malignancies here. First, exocrine pancreatic cancer. In particular, tumors arising from the pancreatic head tend to obstruct the common bile duct relatively early. And second, cholangiocarcinoma, or bile duct cancer, which can arise from any part of the biliary system, but primarily affects extrahepatic ducts. Malignant obstruction is classically associated with painless jaundice, but patients can also present with pain and jaundice, as depicted by these twin cowboys, one happily wrastling with a yellow billy goat to represent painless jaundice, and the other twin getting nipped by a yellow billy goat, to represent pain and jaundice. When pain is present, the location depends on the type, usually epigastric with pancreatic cancer, and right upper quadrant in cholangiocarcinoma. Like many malignancies, pancreatic cancer and cholangiocarcinoma commonly present with weight loss. Hence the excessively thin, frail constitution of this goat here. Just none at anything in sight. Ugh. And you know what's worse than getting nipped by a sickly, jaundiced goat? Getting nipped by a sickly, jaundiced goat while it defecates on your leg. Patients with malignant obstruction may report unusually light, clay-colored stools. Why? Compared to other causes of extrahepatic cholestasis, malignancy is more likely to cause complete or near-complete obstruction. The result? Little to no bilirubin reaching